You have been listening to 3 days of different talks about different drugs that are being used for patients with type 2 diabetes, but we need to understand the underlying pathophysiology of diabetes in adults as well as children so that we can better guide our therapy. So we've heard people talk about precision medicine and individualizing therapy, but without understanding why the disease happens or what is the progression of the disease, I think we're just blindly treating patients. So I hope to show you some data which will perhaps inform you on what you should use for medical management of your patients. I have no financial disclosures, which we are required to do as far as US speakers. And the funding for all the studies that I'm showing you came from the NIH, National Institute of Aging, American Diabetes Association, from Mayo Clinic, where I was employed for about 26 years, from the CCATS, and now from the University of Virginia, where I'm currently employed for strategic investment funds for diabetes. So this is a common scenario. All of you see patients like this every day, I'm sure. So it's a 50-year-old man, he has a BMI of 30, presents with a fasting glucose of 200 milligrams, despite his best efforts at lifestyle therapy, is what he tells you. And he has noticed that his glucose concentrations 1 to 2 hours after a meal commonly are in the range of 250 to 300 milligrams. So he has fasting hyperglycemia and postprandial hyperglycemia. How many of you have not seen a patient like this? Raise your hand. See, no one. So all of you see patients like this every day in your practice. Why does it happen? So let's look at what happens to glucose metabolism when you're not eating. So this is when between breakfast, lunch, or between lunch, dinner, or between dinner and the next day morning, what happens? There is no food coming from the gut. So everything that is happening, the metabolic effects of glucose are taking place in the liver. So what happens is glycogen is broken down into glucose through glycogenolysis, and new sugars are formed by gluconeogenesis. Gluconeogenesis is the formation of glucose from non-glucose sources, which comes from 3 carbons, breakdown of fatty acids, amino acid products like glycerol, lactate, alanine, glutamine. And these are being utilized by the body. On the other side, you can see the brain is taking up glucose, which is non-insulin dependent, and the rest of the tissues take up glucose, which is insulin dependent. So this is what happens when you're not eating. What happens when you're eating? Now there is food coming from the gut. So there's food coming directly from the gut through the portal vein. It comes into the liver, and some of it is taken up and stored as glycogen. The rest of it is released out into the circulation. But the difference between a non-diabetic liver and a diabetic liver is that in the case of a non-diabetic liver, as soon as food comes in through the gut into the liver, insulin comes out and it suppresses glucose production. But in the case of a diabetic liver, insulin does not suppress glucose production, so there's continuous glycogenolysis and gluconeogenesis. And I'll show you data that we have done to show this. So if there is one take-home slide from this talk, this is it. If you look at this, the non-diabetics are shown in blue, the early type 2 diabetic is shown in orange, and the late type 2 diabetic is shown in yellow. The top panel is glucose concentrations following a meal, the middle panel is insulin concentrations, and the bottom panel is glucagon. This study was done by a colleague of my husband and mine from Mayo Clinic many years ago, published in Diabetes in 1991, Peter Butler. I have a picture of him out there. So if you look at what's happening in a healthy person, when they eat a meal, there's a modest increase in glucose. So you can see the glucose concentrations go up slightly, the blue curve. And why is the glucose modestly going up? Because there's a robust insulin response. Insulin concentrations are going up immediately with the first bite of the meal. And you can see that blue curve nicely going up. And then the glucose has come down because there's enough insulin on board. Look at the bottom curve. What happens to glucagon? As soon as they eat the meal, the liver senses and glucagon starts suppressing. Now you look at the orange curves. The orange curve is the early type 2, which means their fasting glucoses are probably around 140 or so. And so if you see that, the orange curve, the glucoses are higher than the blue curve. So they are sort of 140, 150 milligrams per deciliter. Insulin response is very slow. You can see the orange line. Insulin comes up slowly, and then that helps the glucoses come down. And glucagon is high. So glucagon does not suppress with a meal. Now look at the late type 2 diabetic. So the blood sugars are probably 180. You can see 10 millimolar per liter translates to 180 milligrams per deciliter. So when you look at the yellow curve, the blood sugars are high and remain high for a long period of time. So 5-6 hours after the meal, the blood sugar is still high. And why is it high? Because look at the insulin, yellow curve in the middle panel. There's barely any insulin coming on in the circulation, and glucagon is high. So the combination of low insulin and high glucagon causes the blood sugars to remain high and remain high for long periods of time, okay? So what we set about doing, and that's the hospital, that's Mayo Clinic, St. Mary's Hospital, where all these studies were done, what causes fasting and postprandial hyperglycemia in people with type 2 diabetes. So this study was done by Dr. Firth, who was a GI physician. He's back in Ireland. This was published in 1991. And what he showed was, if you take lean, healthy patients and lean diabetic patients, and you look at obese non-diabetic and diabetic obese, the curve for glucose utilization doesn't matter what kind of insulin dose you're studying, is always shifted to the right. So you can see in lean people, the lean diabetic gets shifted to the right from the lean non-diabetic, and when they're obese, it's even further shifted down to the right. So which means glucose utilization is less and less with the obese diabetic as compared to the other groups. Look at what happens to the liver, glucose production. Utilization is in the peripheral tissues. Glucose production is in the liver. So as I mentioned to you, diabetic liver continues to make sugar. Doesn't matter what happens. So despite the physiological concentration of insulin going from 10 units per liter per ml to all the way to 3,000, the curve is, again, as you can see, glucose production is high and remains high, and in obese diabetics, it remains highest. So the liver continues to make sugar despite the fact that there's a lot of insulin or less insulin on board. So those studies that I showed you did not use any isotopes, so we can't tell whether it's in the exactly where are the defects. So when I started at Mayo Clinic and I finished my fellowship, I had the chance to develop what is called the triple tracer meal method, which has now become the gold standard for meal measurements. And the reason it's a gold standard is because using this methodology, not only can we measure glucose fluxes, but we can concurrently measure insulin secretion and insulin action. So we use isotopes. So I'm going to show you, just give you the broad outline. You can read up the paper. So we give 3 isotopes. One isotope is mixed in the meal, which is 113C glucose, and we give 2 intravenous infusions. One is D2 glucose, shown in blue, which starts at 2 hours before the meal is fed, and we use that to trace the basal endogenous glucose production, so how much the liver is making in the basal state. And when we feed the meal, we turn down that infusion because we expect the liver to start suppressing when the meal starts coming in. Conversely, we know that the meal is going to appear in a certain pattern, so we start the 3rd isotope, which is the tritiated glucose infusion, in a pattern that we think will anticipate or mimic the appearance of the meal. So this is known as the triple tracer meal method, and I think it's being widely used all across the world now. So as I mentioned to you, what this method does, or the model does, is it's the gold standard for measuring meal fluxes and insulin action and secretion. So we use certain terminologies, and some of you may be familiar with this. We call Phi total, or Phi total is a global index of insulin secretion, and it is the sum of Phi static and Phi dynamic. So phi static is when the glucoses are not changing. So towards the later part of the meal or the early part before we feed the meal, when glucose concentrations don't change, the amount of insulin secreted in response to that is measured by phi static. Phi dynamic is when the glucoses are rapidly changing. So as we are feeding the meal, glucose concentrations are rapidly rising in the plasma, and that is measured by phi dynamic. SI is the index of net insulin action. So it is the measure of the ability of insulin to suppress glucose production in the liver and stimulate glucose uptake in the peripheral tissues. And the composite is known as disposition index, which is a measure of beta cell function appropriate for the degree of insulin resistance. So these terminologies are important because you may be reading a lot of papers where people are publishing this kind of data. So my husband, in 2009, he published a study where he used that triple tracer meal method and looked at patients who have diabetes and don't have diabetes. And what he showed was that when you feed people who have diabetes and don't have diabetes, a meal, which is a standard meal, there is no difference in meal appearance, as you can see from the figure. So the meal is handled the same way. What is different is endogenous glucose production. So the liver does not suppress as much in a diabetic liver as it does in a non-diabetic liver. So as you can see, the yellow lines are higher, the blue lines are lower, which means the non-diabetic liver suppresses more, which means less glucose is coming out in the peripheral circulation. Glucose disappearance, which is how much is taken up by the peripheral tissues, is much, much lower in patients with type 2 diabetes, which means you can feed them the same meal, but the diabetic person, their glucose uptake is much lower and their glucose production is higher. These are all the reasons why they have the postprandial hyperglycemia. So now, if we think about muscle glucose uptake, is there any impairment of hepatic or muscle glucose uptake would be the next question, because we are trying to tease out why is there postprandial hyperglycemia. So to do these studies are very difficult. We did that at Mayo Clinic. We had set up a way so that the interventional radiologists were putting in catheters in the hepatic vein, femoral artery, and the femoral vein, and we were able to quantify what happens as the sugars go across the liver. So before the liver and after the liver, as you can see in the cartoon. So what is happening in the hepatic artery or portal vein, we cannot put catheters in the portal vein. So whatever is happening in the arterial side, we measure through the femoral artery. And on the hepatic vein, of course, we have a catheter. So we look at splanchnic balance. And what these studies showed was these are hyperglycemic, hyperinsulinemic clamps. So essentially, we are mimicking what happens after one eats a meal. When we eat a meal, blood sugars go up, insulin goes up. So that's hyperglycemia, hyperinsulinemia. So what he showed was that it doesn't matter what dose of insulin you use, splanchnic glucose uptake, or the amount of glucose that is taken up by the liver after a meal, is much lower in patients with type 2 diabetes, and the leg also takes up less glucose. So if the leg is taking up less glucose, if the liver is taking up less glucose, then more glucose is coming into the peripheral circulation. So you'll end up with postprandial hyperglycemia. Then we did further studies because we wanted to tease this out some more, and we used various doses of insulin. Again, same hyperglycemic, hyperinsulinemic clamp using splanchnic catheterization, and showed that splanchnic glucose uptake is indeed lowered. So the dose response is lower in type 2 diabetes than in non-diabetic healthy people. And if you look at now endogenous glucose production, there is much more glucose coming out of the liver, despite the fact that there is hyperinsulinemia and hyperglycemia. So it translates to, after a meal, the liver in a diabetic person continues to make sugar. It doesn't stop, and that's what this graph shows. On the other hand, glucose disappearance is lower. So you are hit by, they're both defects happening at the same time. The liver continues to make more sugar, and less is being taken up by the peripheral tissues. So then the question is glucose production increased in mild or severe type 2? Is there a difference in mild versus severe? Because some of your patients have, fastings in their 140s and some come in their 200s. So is there a difference? And yes, there is. So endogenous glucose production continues to rise. So this was a study we did. I'm not going to go into details, but we did clamps, And if you can look at the right-hand side, we gave somatostatins, so the pancreas is knocked out, so we are matching the concentrations of hormones in all groups. So if you look at what happens, there's 11.2, 11.4, which is millimolar. That's the glucose concentration. So the persons who don't have diabetes and who have mild diabetes, their glucose concentrations are almost the same, but still EGP is much, much higher, or the liver is putting out more sugar in those with mild diabetes and those with severe diabetes. So you see the defect becomes more apparent when you look at, when you match glucose concentration or try to match hormone concentrations in the pancreas, then the defect is more clear to see. So glucose production continues to be high in those who have mild diabetes and who have severe diabetes. And if we partition this by using various techniques, and the one I use is I give deuterium-labeled water, and I can measure gluconeogenesis, what it shows is gluconeogenesis continues to become higher and higher when patients have severe diabetes as compared to mild diabetes. And glycogenolysis is also higher in patients who have mild versus severe diabetes as in comparison to a healthy person. So the blue line, as you can see, the no diabetes, on the right-hand side, there's hardly any glycogenolysis taking place, whereas in the patient who has diabetes, whether it be mild or severe, continues to take place, so which is one of the reasons why they continue to have postprandial hyperglycemia. So now to change to what happens in prediabetes. So in prediabetes, this is a study done by one of our fellows at Mayo and published in 2007 in diabetes. So the top panel shows net insulin action. So I already explained what is the definition of insulin action. As you can see, the people that have normal fasting glucose and normal glucose tolerance are represented in blue. The people who have impaired fasting glucose are represented in yellow. So there is a marked reduction in insulin action shown on the top panel, and effect of insulin on glucose disposal, which is on the peripheral tissues, is also reduced in those who have impaired fasting glucose. Now, if you break down the subjects, the patients who have impaired fasting glucose, they could be isolated IFG with normal glucose tolerance, which is the pale yellow, could be normal fasting glucose with impaired glucose tolerance, which is the green curve. They could be both combined IFG and IGT, or they could have diabetes, which is IFG-DM. This is after an oral glucose tolerance test. So as you can see, the curve is beautifully represented as the defect is getting worse and worse, insulin action is going down. So the pink is the lowest and yellow is the highest. And if you look on the bottom curve, the same applies to effect of insulin on glucose disposal, that as the defect gets worse, SI star starts getting worse and worse. What happens to insulin secretion? As I explained to you before, the top panel shows total insulin secretion, the middle panel is dynamic secretion, the bottom panel is static secretion. Again, even though there's no statistically significant difference, but you can see the curves are going down as the defect is getting worse. Now, if we take both insulin action and secretion into consideration, then we get this terminology called disposition index, which I explained to you a little while ago. So the top panel shows disposition index, which is overall total. The middle panel is in the dynamic state when glucose concentrations are rapidly rising, and static is when the glucose concentrations come down, say a few hours after a meal, and they're staying almost flat. But the defect is very clear, so as the patients with IFG, IGT are worse than the isolated defect, and the ones who have IFG, DM clearly are worse off. So this is a very nice way and you can use this to understand what happens, because when you see a patient who has combined IFG, IGT, you can now picturize in your mind that these are probably the different defects that are occurring in this patient. So now, since I was asked to talk about youth as well as adults, I'll touch upon the few studies that have shown data in youth. And these are not studies that I have done, but I have borrowed some of the slides from one of my colleagues at Yale, Sonia Caprio. So this was a study, this was a paper that was published in 2017 in the New England Journal of Medicine. And what they said was, look at the incidence of type 2 diabetes in the US youth. And I'm sure this is sort of representative of the rest of the world because there is a huge increase in childhood obesity. So if you look at this graph, all it says is that there's an exponential increase in incidence of diabetes in youth, which we never used to see 20 years ago because we always thought type 2 diabetes was a disease of the elderly. But now we see younger and younger children have type 2 diabetes. And those of you who are in pediatric practice, I'm sure identify with this. So this was a study that was published in about 2012, 2013, the Today study. And what it showed was that there was a rapid treatment failure in type 2 diabetes youth, and it was associated with the loss of beta cell function. So what this study showed was there was an aggressive loss of beta cell function in children and young adults who have type 2 diabetes, much more than what we see in adults. So in adults, it could take time. So it may take time when they develop prediabetes to when they develop type 2 diabetes. There may be a period of 10 years, 15 years, who knows, or maybe even some people maybe less. But in children, when they develop beta cell function or they have loss of beta cell function, they rapidly progress to type 2 diabetes. So then, since there were not that many randomized trials done in children, this study came up a few years ago, and I was fortunate to be on the Data Safety Monitoring Board of this trial. This was a large NIH multi-center trial. It was called RISE. RISE stands for Restoration of Insulin Secretion. And the primary question that RISE asked was, in obese adolescents with impaired glucose tolerance, or recently diagnosed type 2 diabetes, can beta cell function be preserved or improved during 12 months of active treatment and maintained for 3 months following the withdrawal of therapy? This is a commonly asked question. We have debated it in the adult field, and so they wanted to ask this question in the young group. So the pediatric medication arm of RISE had a metformin alone arm where metformin was titrated over 4 weeks from 500 milligrams per day to 1,000 milligrams twice daily, and the dose was modified if necessary due to GI symptoms. And it had a glargine followed by metformin arm where they started with once daily insulin glargine, titrated twice weekly over 1 month based on the daily SMBG goal of 80 to 90 milligrams per deciliter, and glargine was discontinued after 3 months and metformin was titrated. So the unique features of the RISE study design was that they did a 2-step hyperglycemic clamp. And the reason they did this was that this was a robust approach to quantification of insulin sensitivity and beta cell response to both glucose and the non-glucose secretagogue arginine in both youth and adults. And they felt that this would provide mechanistic insight into how the tested interventions affected the 2 key metabolic defects of type 2 diabetes, which I showed you before in adults, insulin sensitivity and beta cell response. So this was the primary design of RISE, and they looked at the primary beta cell function outcomes, which they measured as steady-state C-peptide paired with insulin sensitivity. And if you look at this slide, if you look at the baseline data, which is in a black box, and then glargine followed by metformin, which is the green, and metformin alone in the brown, you can see that from 0 to 12, there was slight improvement, and at 15 months, it's back again where it started. So as soon as the drug was stopped, following the 3 months of withdrawal, there is no improvement in further improvement in beta cell function. So largely it was a negative trial, but it gave us a lot of insight into what happens in children. And then what they did was they looked at the declining beta cell function during treatment with glargine followed by metformin or metformin alone. So, as you can see again, same thing here. At 0 is the baseline, 12 months is when they were treated, and at 3 months later, 15 months when they measured beta cell responses, we're back to square one. So nothing happened. So, there's a lot of theories that if you treat people with insulin, it may preserve beta cell function, et cetera. Doesn't appear to hold good. So what have we learned from the RISE pediatric medication study? That in obese youth with impaired glucose tolerance or early type 2 diabetes, glargine metformin was not superior to metformin alone in preserving beta cell function. Glycemic improvement was not sustained on either therapy that they gave, and after withdrawal of intervention, beta cell dysfunction progressed in both treatment arms, whether you calculated with the clamp, and they also did the OGTT. So these findings sharply contrasted with previous studies in adults showing an improvement in beta cell function with metformin or insulin for type 2 prevention and treatment. So this is the difference between in the adults and the pediatric arm. So the implications of RISE was that early treatment of youth with IGT or type 2 diabetes may require other medications alone or in combination, or we may need to give it for longer periods to combat the severe insulin resistance of puberty and arrest the progressive loss of beta cell function. Because remember, these are pubertal kids, hormones are coming into play, so their disease is more aggressive and they're more severe insulin resistant than adults. And the results of the RISE pediatric medication study called for, of course, further studies to better understand the physiology underlying beta cell dysfunction in youth to identify effective treatment options for them. And we, of course, need better approaches to prevent and treat childhood obesity, and this is a critical need across the world. So to summarize what I showed you, people with type 2 diabetes have impaired insulin-induced suppression of glucose production, which means the liver doesn't shut off and continues to make sugar, impaired insulin-induced stimulation of muscle and splanchnic glucose uptake. So essentially, when a diabetic person is eating a meal, not all their sugar is being taken up by the liver. So splanchnic glucose uptake is low. Splanchnic means, gut, omentum, liver, everything is splanchnic. So there's less uptake, which means more is coming into the circulation. And they have abnormal glucose-induced stimulation of glucose uptake. So less sugar is being taken up the muscles and other tissues. And I also showed you that pre-diabetes and diabetes are associated with defects in insulin secretion and impaired hepatic as well as extrahepatic insulin action. So this is your armament. This is what you've been talking about for 3 days now. So there is all the drugs in here. Everything that we have so far, I think I've listed, or I may have missed one or two here and there maybe, and they all act on different things. So some help to reduce muscle glucose uptake, some will help to suppress glucose production or combat insulin resistance in the liver. They could help by improving insulin secretion, but whatever it is, remember that the disease that is presenting to you depends on the patient, and whatever patient profile comes up, you need to intelligently apply your armament to these patients. Don't just start with one drug all the time because it may not work for the various groups. And in children, it may not work at all. So therapy directed at correcting the specific metabolic defect in a given individual is more likely to be successful in either treating or preventing diabetes than treating everyone the same regardless of the underlying cause of their hyperglycemia. This is, in my mind, the definition of personalized medicine. So, this famous doctor who's known as the father of glucagon gave a Banting Memorial Lecture in 1975 when I was still in school. And what he said still holds true today. He said, when science fails us, biotheologic inference and common sense may provide the best available basis for a guess. So nature's efforts are seldom purposeless, and nature makes a substantial effort to avoid hyperglycemia throughout life. So with that, I want to show you a picture of all the people behind the scenes who worked very hard so that I can come here and present this. This is the team we left behind at Mayo, and then this is the new team we are building up at the University of Virginia. And of course, I do want to take 2 minutes to show you my family, because the family is the most important dynamic in all our lives. So, very proud grandmother of a 10-month-old Mira. And on that side, I have my 2 daughters in the center, Nivedita, who's a hospitalist at Emory. Next to her is a sister, Devika, who is a clinical psychologist at Emory. I have Nivedita's husband holding the baby, he's a pediatric cardiologist, and the gentleman on the right who is going to marry my younger daughter is an economist. So we have covered every base in our family. And I wanted to leave you with this. Thank you so much for your attention.
Dr.
I'm happy
Basu,
to take questions.
yeah.